Good evening. This is the meeting of the Health Overview and Scrutiny Committee. We'll start with nominations for a chair, please. Councillor Mather?
Yeah, I would like to nominate Beth Rowland.
Do you have a seconder? Do we have any other nominations? Thank you, Councillor Bay. Okay. Could we take a vote, please? All those in favour? Okay, thank you. Councillor Rowland?
Thank you very much, everyone. Need to be a bit nearer the
Especially if I turn it on. I've got my hearing aids on tonight, yeah.
Take a vote on the vice chair.
Oh, can we have a vote on the vice chairman, please? Thank you. Do we have any apologies?
No.
No. Minutes of the previous meeting on page 5, which seems a lifetime ago now. Is there anything on page 5? 6, 7, 8, 9. No, are you happy that I sign those as a complete record of the meeting? Thank you. Can I have a show of hands, please? Thank you. Any declarations of interest? Any questions from members of the public?
None.
Any member questions?
No, none.
Okay, we've now got a presentation on maternity service. I'm not sure who's doing it. Oh, Christine.
Hello, can you hear me? Hello, can you hear me?
Yes, thank you.
Hello, my name's
Thank you,
Christine.
Christine.
Hi, I'm the Director of Midwifery at the Royal Berkshire Hospital. If it's okay, I'm just going to share my screen. I just find the right screen to share.
If you can't make it work, Christine, we do have a copy in front of us.
Do you?
Yeah.
I mean, I've got it already. I've got quite a lot on my computer.
That's all right, we bear with you because you'll have it in glorious Technicolor.
I do have it in Technicolor. It's just finding. Finding the one that's open, that's the problem. It is the only thing that's open on my screen, so I don't know why I can't find it. Oh, let me see if this works. Am I sharing anything yet?
Yes, you are.
Oh, perfect. Sorry for the delay with that. Has that put that in slideshow so it's a little bit bigger for you?
We can see the whole screen in the side pages as well.
Oh, can you?
Yeah.
Okay. Is that going to be okay? I'm not sure how to.
If you select from beginning, that should help.
Okay. Well, that is the first slide. So is that not the beginning? Is that okay? I don't want to cause any more delay. Do you think is that going to be acceptable?
So if you just click on from beginning at the top left of your screen, that should make it bigger.
I haven't
make
got
it full screen.
Wait a minute, I haven't got from beginning. I've got, wait a minute, display settings, no. I can't see from beginning at the top.
Don't
Don't
worry,
worry, just carry on.
yeah, we'll go with it like that.
I'm ever so sorry. You can tell I'm not used to doing this, can't you? So, thank you once again. My name's Christine Harding. I'm Director of Midwifery at the Royal Berks. And I've been asked to come along this evening to give you an overview of maternity services and in particular an update on perinatal mental health from the perspectives of the Royal Berkshire Hospital. I'm hoping that slide's moved on. Please do just shout at me if it hasn't. So by way of a bit of background, this slide...
It hasn't moved on yet. If you select from beginning, if you go to the very left-hand corner at the top of your toolbar, down slightly. That's it, click. Click.
Yeah, there's nothing on my screen.
Okay, sorry.
Let me start.
That's it, it's moved on.
Has it gone back?
Yeah.
Has that moved on?
No,
No, right, let's go back to that. I think it's if I try and put it
that's
in
it.
slideshow. So I'm not going to put it in slideshow. Hopefully you can see it big enough because I'm not sure why it's not working for me.
So long as you can deal with maternity services, we're not worried about computing.
Well, that's a relief. Thank you very much. So by way of a bit of a background, this slide just shows some of the activity within the trust to give you a sense of how busy the organisation is. The maternity services really are at the heart of the organisation, and one thing that we're most proud of is how well it's integrated and supported into the wider trust. So the trust provides maternity services for a population of Reading, Wokingham, Newbury and the towns and villages of West Berkshire, with about 5,800 bookings a year and approximately 4,600 births. On a typical day, there are 15 babies born across 3 settings and many more appointments, screening tests, admissions and discharges. In terms of the population of Wokingham specifically, last year 25% of our bookings were from the Wokingham area and 29% of our births. In addition, we cared for a further 660 women in the postnatal period after they'd given birth at other organisations. A proportion of these would have been from the Wokingham area. It goes without saying that there are significant challenges for maternity services at the moment. Over the last 10 years or so, we've seen an increase in the complexity of families we care for, with an increase in demand for caesarean birth, induction of labour and maternity ultrasound. Of course, we strive to meet these demands in what is currently quite a challenging financial climate. Birth inequalities is an area that we are more and more aware of, with publications from successive confidential inquiries highlighting the higher probability of poor outcomes for families from the global majority and areas of deprivation. In addition, there is significant national scrutiny, with several published reports into failings at different organisations, such as the East Kent, Shrewsbury and Telford, and the Nottingham Review is due to be published in the next 12 to 18 months. All of these have implications for us as a service, but more importantly, have impact on the families that we serve. We're aware that public confidence is low, and this adds significant risk, with many organisations seeing an increase in families declining recommended care. So an important focus for us is the ongoing monitoring and reporting of our outcomes and prioritising improvements, which are shaped by the significant involvement of our partners and service users. It's also important to celebrate our successes, and we had our maternity inspection from the Care Quality Commission in November last year. This inspection focused on safety and leadership. At the time of the inspection, there'd been 132 maternity services inspected, with the majority receiving a rating of inadequate or requires improvement. We were rated good overall, good for well led and good for safety. And in fact, we were one of only 9 organisations nationally who increased their rating for safety since their last inspection. This is something we are incredibly proud of. However, we are continuing on our journey because we're very keen to be rated as outstanding in the future. So in the next few slides, I'm just going to give you some examples of how the maternity service is functioning under the headings of the CQC National Inspection Programme. Over the last 2 years, we've been focusing quite heavily on our midwifery staffing levels, and due to different initiatives, we've seen our vacancy rate fall significantly to 7%. And currently we've got some vacancies for student midwives we're training who will be joining us in the organisation once they qualify nearer the end of the year, and therefore we're expecting this figure to drop even further. In fact, our last recruitment day this spring was the first time that we've had to open a waiting list for midwives wanting to come and work at the Royal Berkshire Hospital. One of the initiatives that has helped us to achieve this has been the recruitment of internationally educated midwives. Since we launched this back in 2020, we've employed between 25 and 30 internationally educated midwives. The career development and support that we've put in place for this group and for all our midwives is now seeing some of them achieve some promotion within our organisation, which really supports our ambition to have a diverse leadership group. The support and development pathways have also helped us improve our retention of midwives, and we've seen our turnover figure halve over the last 12 months. We've also seen investment in the obstetric workforce with recruitment of obstetric and gynecology consultants, meaning that we're able to offer 162 hours of consultant cover a week, which is in line with the national safety recommendations. Perinatal mortality, so that's the deaths of babies either before they're born or in the initial postnatal period, is clearly a very significant measure of safety for the service and is something that we prioritise with a thorough perinatal mortality review process. This process centres on the experience of the families and ensures that we identify and implement learning. Currently, our perinatal mortality rate is below the published national figure. One of the significant things that's helped to reduce perinatal mortality is the introduction of the continuity of carer model for vulnerable families, vulnerable either due to social deprivation or due to significant mental health. National data tells us that perinatal mortality is doubled for those families from the highest areas of deprivation. However, when we've analysed our outcomes for these areas in Reading, where we have continuity of carer teams, we're seeing a low perinatal mortality rate. Analysis of this data has enabled us to identify other areas where we can focus our resources when we're able to introduce more continuity teams. Last year, the Trust introduced a new initiative for continuous quality improvement called Improving Together. This whole Trust initiative came with training for how to successfully implement and sustain service improvement projects. The maternity focus so far has been on two significant areas. The first of these is avoiding term admissions to the neonatal unit, which has a significant implication not only for well-being of babies, but for separation of babies and their parents. Over the first 6 months, this project resulted in a significant and sustained reduction, which put us back in alignment with national and regional figures. The second significant project was the introduction of the maternity assessment unit and face-to-face triage. We knew that this was something that the CQC were focusing on as a measure of safety. It involved a wholesale change for how women who attend the maternity unit for an urgent or unplanned reason are assessed. The national standard is for 80% of women to be triaged within 15 minutes of their arrival. Prior to launching this initiative, we were unable to identify how long women were waiting for their assessment or use any evidence-based methodology to prioritise the order or time frame for their assessment. We've made improvements to the physical area with 2 new clinical rooms, increased the workforce, and introduced a recommended tool for triage and ongoing assessments. We're not quite at our 80% mark yet, but we're on a trajectory to reach this. In the last year, we've introduced a series of pregnancy after loss care pathways, which ensure that women receive the best possible care in pregnancies after suffering a loss, whether that be a loss over 16 weeks gestation for any reason, or a loss relating to a fetal abnormality at any gestation. 4 different pathways of care, including our rainbow pathway, ensure that families receive the appropriate and enhanced care relevant to their specific circumstances. This is from specialist midwives, obstetricians, and the fetal medicine team. We know that according to published national evidence, families who've had a previous loss are up to 5 times more likely to have another one. However, the initial evaluation of our pathways has shown that the risk for families in our care is significantly lower. Maternal medicine is another area of focus, with recommendations coming from the first Ockenden review at Shrewsbury and Telford for strong networks to be developed within the region to ensure that women with complex needs receive appropriate and highly specialist care. We've a very active maternal medicine network within our system and a midwifery and obstetric lead within our trust. This means that women are referred promptly and receive joined up specialist care. In terms of our response to improving outcomes for diverse groups, we've introduced many initiatives. One area of significant focus is access to services, and particularly ensuring that the pregnancy is booked by 10 weeks of gestation for those from Black and Asian groups. We know that the earlier women access maternity services, the greater their opportunity for appropriate screening and antenatal care. Using the Improving Together methodology and the Equality Delivery System, our approach involves looking at existing pathways, working with local groups to identify what we can do better to be more responsive to their needs, and working on the improvement plan. As an example, one of the exciting initiatives we're involved in is the production of information for Black African women to advertise maternity services and promote this early booking. The aim of this is for the Black African community to produce and own this information with our support, rather than simply receiving something that we have produced. I've already mentioned some of the ways we're tackling health inequalities, and I'd like to think that we've come a long way in the last 2 years to understand what this looks like and what we need to improve. With the leadership of our EDI lead midwife, we've introduced training for all staff, as we strongly believe that knowledge is the first and most important step for us all. All of our data is presented with a focus on ethnicity and diversity, and we're focusing on improving all access to services, whether this be through the booking processes or use of translation and interpretation. We need to focus on other protected characteristics, as it's all too easy to forget that health inequalities are so much more than ethnicity alone. For instance, we've recently started working on a pathway for women with learning difficulties, including but not only those with autism. Partnership working is so very important, and we're very lucky to have a very active and enthusiastic maternity and neonatal voices partnership. We completely recognise that this group do not represent all families in our care, but they have a massive role to play in reaching out to the community and engage with different groups to inform our service. Most recently, they've welcomed some community engagement leads whose main role is to do just that, to engage with the community. Before I go on to talk about the community groups that we're working with, I just wanted to give a couple of examples of initiatives where we've used co-production. We launched our maternity strategy in 2022 with some key priorities agreed by the multi-professional team and service users. Currently, we're agreeing on new priorities for the coming 18 months, with the most important service user voice at the heart of these conversations. Our Seeking Sanctuary project has been incredibly positive and only successful due to collaboration with many different professionals and groups. This is the specialist maternity clinic for families who are refugees, asylum seekers, those fleeing conflict, undocumented migrants, and people who've been trafficked. The one-stop shop, held every 2 months at a local children's centre currently in Berkshire West, gives an opportunity to break down the barriers to care for pregnant mothers and their families. Partnership working between midwives, obstetricians, health visitors, sexual health, the Reading Refugee Support, local charities, and Meet Pete, which is the patient engagement and experience team at the hospital, with support from interpreters, mean that antenatal care and education can be given alongside support with the many problems that this group of people are faced with. This initiative has been recognised nationally and was included in the NHS 3-year maternity and neonatal delivery plan, which was published by NHS England. 15 Steps is a recognised initiative which invites service users and staff to walk through the service with fresh eyes in order to identify improvements to the environment. It's usually held every 6 to 12 months so that these improvements can be implemented and evaluated. Some of the things we've improved as a result of this are around our signage, our decor, and our overall presentation of the department. We'll be extending this to the neonatal unit next time as well. Our birth reflection service is another way that we're able to respond to service users. This is open to anyone who wishes to discuss their birth, and there are no timeframes in which that they need to do this. Families can self-refer, or we often make contact after a health visitor or GP has got in touch, having recognised a need for this discussion. Themes from the feedback that this generates are fed into the midwifery services, the governance and the intrapartum strategy groups, and become part of the relevant improvement plans. As I said before, partnership working is so important within maternity service, and as this slide shows, these are just some of the groups that we're engaged with. Our MNVP have been very active within Wokingham, attending the Involve voluntary networking event, meeting with Health Watch leads to build relationships, meeting with Debbie Loughlin, who I believe is the Children's Rights and Advocacy Officer at Wokingham Borough Council, who's helping us to ensure we hear the voices of young parents in the care system, reaching out to CLASP, a charity who support adults with learning difficulties so that we have a link for future projects, and organising listening events, and reaching out to various libraries, home start groups and well baby clinics. Outside of Wokingham, one of our consultant obstetricians spoke at a celebration event during Black History Month to promote maternity services, and we've also been represented at the Health Inequalities Conference, which was supported by ACRE and Utilivu, as well as undertaking a lot of community events and listening events. So moving on to the mental health update, in terms of the mental health pathways, we start with a mental health risk assessment, which is undertaken at every booking appointment. This will then trigger referral depending on what is disclosed, and I'll come on to what those pathways are on the next slide. Obviously, it's really important that the risk assessment is repeated and questions are asked about mental health at every midwifery and obstetric encounter during the antenatal period. Each service that we have access to sets out their own specific referral criteria. However, when this doesn't quite match the individual requirements, an individualised assessment is undertaken by the multidisciplinary teams to ensure as far as possible that needs are met. As I've said, the pathway is dependent on the individual needs of women. We have 8 community midwifery teams who liaise with GPs, health visitors, charities and community partners. Our Poppy midwifery caseloading team support families with complex needs, social, psychological and physical, working collaboratively with health visitors, safeguarding team, local authorities and children's social services, as well as offering enhanced postnatal care. In addition, there are referral pathways to the perinatal mental health team at Berkshire Health, and for acute situations for those who are inpatients, you can refer to the psychological medicine service for immediate assessment and support. We run a fortnightly Berkshire maternal mental health clinic, which has an annual caseload of about 135 women. This is a multi-professional clinic led by a specialist midwife, obstetric consultant and perinatal mental health specialist practitioner. They link with the wider multidisciplinary team, including an advanced clinical practice trainee, psychological medicine clinician and consultant midwife to ensure that plans for care are appropriate. The team of consultant midwives work very closely with Birth in Mind, the birth trauma pathway, with monthly collaboration and shared care planning for women with psychological and obstetric complexities. I've already mentioned the Rainbow team, who offer a case loading model for pregnancy after loss, And we have a neonatal clinical psychologist who supports families whose babies are in the neonatal intensive care unit. As mentioned, we have an advanced clinical practitioner trainee who has a special interest in perinatal mental health, and we're looking at the functions for this role once she's qualified. They'll most likely be to support those with mild to moderate mental health concerns. Other initiatives to support the mental health pathway include a perinatal mental health huddle, which was introduced recently. This is a monthly drop-in online session hosted by the trainee ACP and consultant midwife, where midwives and obstetricians can drop in to confidentially discuss care of the women in their care. And also it means that staff are supported with recognising mental health deterioration and signposting to other primary care services or charities, such as Mind, Talking Therapies, Home Start, Alana House, and the Maternal Mental Health Alliances. There's also a process for referring individuals discussed at this safety huddle into the Berkshire Maternal Mental Health MDT clinic if necessary. We've introduced mandatory training for all midwives, support workers and obstetricians in the management of acute mental health crisis, delivered through simulation training. In addition, all staff receive mandatory safeguarding training for vulnerable adults, and obstetricians also receive training on prescribing the relevant mental health drugs used in pregnancy and while breastfeeding. One of the initiatives that we've recently introduced to support maternal mental health and wellbeing is the introduction of the family bays on Marsh and Iffley, our postnatal areas. This initiative was co-produced with our service users and in response to feedback. 2 family bays mean that in addition to the single rooms, women can have their partners stay with them 24 hours a day to support them after the birth of their baby. It's currently a pilot, however, the initial feedback has been really positive. It's fair to say we learned a lot during COVID, and we know that separating mothers and babies from their support has a significant negative impact on them. We've also introduced a telephone triage care card to support midwives taking calls from families to help them recognise deterioration of mental health and aid signposting for the safest place for ongoing care. And I've already mentioned the co-production of our maternity strategy and the birth reflection service. So just to finish on, these are some of the ongoing improvement projects that are still underway. We're co-producing a new standardised postnatal discharge proforma, which will include the relevant mental health and safeguarding questions to support effective handover of care to primary care services. Recently, we've piloted a personalised care and support plan, which was created by the Berkshire, Oxfordshire, Buckinghamshire local maternity and neonatal system. This includes mental health and wellbeing signposting, and it's currently available in 17 languages. However, now it needs some revisions, and ideally we'd like to have a digital solution as well. Alongside these revisions, we're also planning to adapt and include the Together Project Toolkit, which was published by the University of Surrey. This toolkit supports individualised care planning for those who are considered to be neurodiverse, have learning disabilities and maternal mental health. We're also hoping to get some funding into launching a postnatal 3 to 6 month debriefing project for those who have experienced an emergency situation during their birth to improve our responsiveness and identification of PTSD early in the postnatal period. And last but by no means least, we're commencing a scoping exercise with our Health Visitor colleagues, Birth Reflection Service and Birth in Mind to explore what resources are available for partners experiencing birth trauma. This will align with the recommendation for PTSD assessment and support for partners experiencing birth trauma, as was highlighted in the recent parliamentary birth trauma inquiry. So I'll come to the end of my update now. Thank you ever so much for listening. And obviously I'm happy to take any questions.
Thank you, Christine. That was a really thorough walk through maternity ward and covering lots of subjects. And I'm sure we have some questions. Let's open up the floor first of all. Rebecca.
Thank you. It's really interesting to see that you've got so many initiatives kind of covering a very broad spectrum here. How does it actually work though on the ground? Because I can see there's all these wonderful things that on paper that you're doing, but how many people do those services actually get to? You know, how restricted are you with resources to actually provide those services?
So that's a really good question, and I by no means want you to think that I'm just showing you and showcasing the things that we're doing well at and the things that we are appearing to be doing well. As I mentioned, there are quite a lot of pressures on maternity services at the moment, particularly around resources and around cost and finance. But we do monitor our outcomes, and we do monitor the involvement of our staff and our service users. And I'd like to say that all of the projects that we've got going ahead, yes, they'll have their challenges and they'll have their things that are causing a bit of a blockage. But we are very proactive, and we've got a very good team working. So I would like to say that all of them are moving forward and are actually having a positive impact on our service users. We obviously have a lot of service user feedback, so we know there's always things that we need to improve, but the things that we are focusing on at the moment, I think, and I think that's probably the key. We're not trying to do everything all at once. Our strategy priorities, we've come up with such a lot of things that the team want to do, but we've recognised that we need to do one thing at a time or two things at a time, so that we make sure we do them effectively and they have the benefit. So yeah, I don't know whether that's answered your question, but
Yes, Rebecca says yes. Thank you very much.
thank you, Rebecca.
Alice?
Hi, Christine. Can you hear me? Yeah.
Yeah.
Hi. I'm Alice Kunyupi-Clifton. I'm the lead officer for HealthWatch Wokingham. One of the things that I'm concerned about is the communication that is sent out to women. How do you do that? Because we get feedback that there's no communication from the hospital about changes that's taking place. So how have you improved that?
I think there's a wide range of ways that we communicate. Obviously, we communicate with service users when they're in our care. So that's through providing the care that we have through midwives and obstetricians. We are redeveloping our social media platforms and our internet, so that we can reach people who prefer to have a digital way of being communicated with. And it's one of the things that we're asking all of the partners when we're spending a lot of time going into organisations and groups and asking them, how do you want to be communicated with? How is it important for you? And that's one of the examples I gave with the information about booking your pregnancy that we're targeting for Black and Asian women. That's exactly what we're doing. We're going out to their groups and we're saying, this is the issue. We know that there's a barrier to why, we don't know why, but we know that there is an issue with women from your community not booking their pregnancy early enough in the pregnancy. How can we communicate with you? How can we make that better? So I understand your point, Alice, but I think the answer is that there are numerous ways of communicating, and we need to find out from our service users what is the best way to communicate with them.
And I just continue that. Just want to share with you that in the media, there's been talk about Black women having high pain threshold and not being given pain relief, as well as Asian women being considered as princesses. So I think those kind of messages will not get you to engage with the community as well. So I do think, those kind of things needs to be addressed before we can get the trust of the community. That has been one of the experiences that we've had, because that's one of the feedbacks we've had, that, the treatment that they get, the attitude of staff is very important.
Yeah, you're absolutely right, and it is one of our biggest challenges is the media and the messages around maternity services. I'm working really closely with our comms team because I recognise that actually, yes, we've got to be open and transparent, and we've got to say, you know, if we're getting that feedback for us as an organisation, we absolutely need to respond to that. But in response to the wider picture from maternity services nationally, where we cannot influence that, we need to talk about how we are engaging with service users and what we are doing to in a positive way, so that we do get their trust and their engagement with us. So it is a problem. It is a big nationally a problem for all maternity services.
Thank you.
Thank you, Alice. Any more questions? Rochelle, then Alison, then Adrian.
What's your biggest challenge now in your service, and what could be done to have possibly alleviate the problem?
Well, I think I've touched on the biggest challenges. They are the public confidence, so the media, the social media, and the public confidence. We want to work with families to provide care, and we want them to help us, or you know, look at what that care needs to look like. The second biggest challenge probably is the limited resources we have, but the increased demand for cesarean births, for scans, for induction. Maternal choice is so very important, but we do have infinite resources, and that alongside our finance constraints, I think all mean that we've got to work very cleverly with the resources that we have to make sure that we are reaching the women who need the services, and try to work together so that they feel confident and feel able to accept the pathways of care that we're recommending for them. So I think those are the three biggest issues.
Thank you.
Alison.
Thank you. You mentioned that the CQC inspection of November 23 was looking at safety and leadership, and congratulations on increasing your rating for safety. How about the rating for leadership?
So we were rated good for leadership. We felt when we got the draft report, if you've had an opportunity to read it, it reads very positively, especially for leadership. And we did feel that we should have been rated outstanding for leadership. We challenged that back to them and asked them what constitutes outstanding for leadership, and they just felt that some of the examples and some of the things that they had seen didn't quite tick the box for outstanding. I've since been on a visit to an outstanding organisation not too far from our area, and had some conversations with the director of midwifery there and looked at what they do and read their report and asked them about their leadership. And I think one of the issues is that there is just quite a lot of inconsistency within the CQC reports, because some of the things they did, they didn't do what we do well, and some of the things that they did, I felt, well, actually we do that as well. So I think it's really hard to get outstanding. There aren't very many organisations that have outstanding. So we are really pleased with where we are at the minute. But like I say, we're striving for outstanding because we don't want to just sit back and think, well, we're doing okay, so let's ride on that. We always need to improve.
So did you increase your rating for leadership? Was it?
No, we were good before, so we maintained our good standing.
That's good, very good to hear. Can I just ask, you spoke about increased demand for scans, cesareans and induction. Is it now the case that it's very much the woman's choice, and you have to provide whatever a mother-to-be wants?
In a nutshell, yeah, it is. So obviously the scans are, it's to do with lots of initiatives for reducing poor outcomes. There are recommendations for additional scans. So that's not led so much by maternal request, but certainly over the last few years, there has been a shift. And yes, I mean, we spend a lot of time talking to women, presenting the evidence. We have a fantastic consultant midwife group who meet with women to talk to them about the pros and cons, the negatives, the positives. But at the end of the day, if a woman says, I've heard all that, but for me, I want a cesarean section or I want an induction, this is the most important thing for me, then yes, we will accept that.
That's great to hear. Thank you for your answers.
Adrian.
Thank you very much for this report. I think, broadly, I read this as a very positive report, actually. And I think all the projects that you mentioned and the reaching out and partnerships is, exactly what you should be doing. So that's really good to see. Just a couple of smaller questions. When you're looking at staffing, there's 162 hours per week of obstetric and gynae consultant coverage. That's, I believe, 6 hours short of 24/7. What happens in that 6 hours? And have you noticed any increased mortality or increased negative outcomes in that 6 hours?
Yeah, thank you. So that 6 hours is a Saturday and Sunday, a few hours in the afternoon on each of those days. We have obviously the consultant is on call from home, and we have senior obstetricians in the building who will call them. I have to say, if it is horrendously busy or if there's lots going on at that time, they won't just walk away, so they will stay. But officially we have just a few hours at a weekend without them, and no, we haven't noticed a trend. The day and time of day for incidents is one of the things that we do look at, not with all incidents, but with some of our incidents, because we know that, for instance, handover periods when shifts are handing over to each other and between each other, one's ready to go home and the other's just starting but is just getting handover, we know that can be an area that we need to be really mindful that we don't cause any delays in any care in that period. So it is important that we are mindful of that, but we haven't seen any we haven't noticed any difference for those few hours at a weekend.
20 odd years ago, when our children were born in RBH, the maternity building had got concrete cancer and was starting to disintegrate. Have you still got building issues?
Yeah.
Does that affect your service delivery?
So we're by no means the worst part of the organisation, I have to say, from a buildings perspective, but we do have issues. One of the significant issues for us is the fluctuations in temperature. So it gets very hot in the summer, it gets very cold when we have bad weather. Those are the things that we need to try and work on, because it's obviously so important that we keep babies warm, whatever the weather outside and whatever the environmental temperature. So we have initiatives like air cooling systems and heating systems, and so there is some investment in the building and in the infrastructure. There are a few estates issues that are sitting on our risk register that we do monitor quite closely, because it is an old building, and obviously we're working very closely with the national team and our local team, looking at what a new hospital would look like and what we would want to have in it, so that we're ready for that as and when the time comes. But yes, it is fair to say that we do have some issues. Usually the worst is around the fluctuations of temperature, I would say.
Oh, thank you for the answers. And, I think, we need to make sure everybody's aware that the buildings generally on site are really not fit for purpose. And, that we do need a new hospital in Berkshire. And that should be near the top of the list of any new government. I think that's all of my questioning. Thank you very much for your answers.
Thank you.
Thank you, Adrian. Can I just check if there are any more? Yeah, Nagi.
Hi, Christine. Can you hear me okay?
Yeah.
So, yeah, you have mentioned we have about 4,000 births every year. And my question is around, have you done any lessons learned where things have not gone as planned? And did you observe any patterns, or did you think there are some training needs, or things like that? Thank you.
Yeah, thank you. So we have various mechanisms to learn lessons. We absolutely do have incidents where things haven't gone as we would have wanted them to, and we triangulate that with lots of feedback that we get from women and families in our care. We monitor lots of outcomes monthly on our clinical dashboard, but also through a reporting system whereby certain outcomes will automatically trigger an incident form to be generated, which gets reported and gets discussed every morning at our operational meeting, and then investigations take on from there. And as a result of that, we have various action plans or improvement plans. We talk to staff so that we can reflect with them as individuals, but also look at the systems and processes to see how we can improve. So there are various action plans or projects underway at the moment that will be as a result of incidents and things that didn't go as we would have wanted. And the perinatal mortality review is one of those such things. So we review all cases where there's been a neonatal death and have ongoing actions that we monitor and sign off and escalate up through the organisation to the trust board so that they are very aware of these things. Another example would be we're monitoring the admission of babies to the neonatal unit, for instance. So obviously we would much rather babies stayed with their parents, but sometimes babies are born and they need some extra support with their breathing or with feeding, etc. So we monitor those every month and we drill down into those cases to really understand, is there anything we could have done differently that would have meant we would have been able to keep the mum and baby together? And again, we've got an action plan, we've got a working group. They present that to the rest of the maternity service at monthly meetings, and again it gets reported up through the organisation to the trust board and outside to the ICB as well. So yes, I think there's quite a lot of that goes on in the service.
Okay. Any more questions? No.
There's just one in the chat. I don't know whether you want me to answer it in the chat, do you?
Are there some in the chat?
There's one in the chat from Sarah Bell.
Oh, yes, please. Could you read the question out to us?
Yeah. So Sarah says she's having some background noise, so apologies for asking the question in the chat, I should say. You mentioned family rooms being trialled and the feedback being positive. I imagine these are very popular. How will access be prioritised to them, and how long are families able to remain in them? So at the moment we've got 2 family bays, so that's a total of, one's got 5, 6 and 8, that's 9 beds, but also we've got quite a few single rooms as well where we accommodate obviously partners to stay overnight. In terms of prioritising them, it is a case of the midwives talking to women when they're giving birth, when they're having their baby, and asking them if they would like to be in a family room. We also have a lot of requests for them. One of the bays is specifically for women who have had caesarean sections, because obviously women who have had a caesarean need more help and therefore would like to have their partner with them. They are pretty much full most of the time, and part of the evaluation will be to look at their use. We're imagining that we will go to this throughout the maternity service. I think that's the way that this will go, so that we will have this facility for all women. But obviously we've got to think about, you know, this is a bit cyclical for us. So, you know, a few years ago we did a survey with our Maternity Voices partnership, and women said actually no, they valued having a bit of time and rest on their own. And also we've got to consider how they might be influenced by everybody else's partner staying overnight as well. So we're listening to service users, we're doing the evaluation. I think it's been so popular that I think we will encourage it, and it'll probably be the default to not have their partner, to have their partner there rather than not. Do we charge for these rooms? No, we don't currently charge for the rooms. Does that answer your question, Sarah and Alice? Yes, got a
thumbs up. Thank you, Sarah.
Thank you very much.
Oh, and a smile. Thank you. Yeah. Any more questions? Thank you very much, Christine, for that very thorough run through maternity services. For some of us, it's a long time ago, and it's totally changed, I have to say, since I had mine children. Thank you very much. If you wish to stay for the rest of the meeting, you're very welcome to. If you want to get on with life, you're very welcome to leave us as well. I know that you're working long hours in the hospital.
That's okay, thank you. I might stay for a bit, thank you.
Thank you very much. The next item on our agenda is the introduction to health and social care officers and professionals. You will see there. And if I could start, please, with the David Hare, who I think is online. David's the executive member with responsibility for health and social care. David, could you show yourself?
Yes.
Thank you. For those of you that hadn't seen him before, that's David Hare. You will, of course, see him in meetings. But more importantly than David, really, turn your microphone off, David, now, so you can't hear, are the people that are sitting on my right, who actually do all the work together with David. Matt, would you like to start and introduce yourself and then the staff?
I will introduce myself and then the staff. So I'm Matt Pope. I'm the Director of Adult Services. To my right.
Evening, hi. I'm Lisa Evans. I'm Assistant Director of Operations and Adult Social Care.
And hi, I'm Lorna Pearce. I'm the Assistant Director for Safeguarding, Quality and Governance in Adults.
And on the screen we have Sanjay.
Yeah. Hi, everyone. I'm Sanjay Desai. I'm the Head of Primary Care Operations for Bob ICB.
And someone else on screen?
Yeah,
Helen.
That's me. Hi, I'm Helen Clark. I'm the Deputy Director for Berkshire West Place within the Bob ICB.
Thank you. And you'll notice Alice has spoken from Health Watch. Alice is very much part of this committee, and it's been very nice recently to see an awful lot from Health Watch on Facebook collecting data from residents. Okay. Did you want to say any more, Matt?
I did, yeah, if that's okay.
Yeah.
I suppose it's new committee, new municipal year. We've had a number of elections, so we didn't really have anyone to talk to about what to put into a session tonight. So what we thought we would do is really have a bit of a conversation about maybe what's on your minds, particularly from an adult social care point of view, so that we could maybe start doing a bit of planning for the year in terms of topics. So I thought we'd start there, really. One ask, though, from myself is that adult social care is just being started to be inspected by the CQC. Some local authorities, a very few local authorities have been through that. Some are going through that. We will go through that. Back in January, we had a what you might call a mock inspection or a peer review. We had that. It went well. There was some learning. And then there's a report on the back of that. I want to publish that report, but one of the things I'd like to do is share that report with this committee. And then one of the sessions through the year, let's plan going through that. Alongside that, one of the key things that we do in preparation for that CQC inspection is we prepare a self-assessment. So that's essentially our overview. I say overview, it is about 70 pages long.
It's, yeah.
Long overview, because adult social care is quite a large topic, but it's our overview and narrative about social care in Wokingham. Volume, what works well, where we think we are, where we want to improve. That's something else that I'd like to bring back here, if we can. Choose a date. In fact, ideally, I'd like that to be September one, if we can. And we'll share that self-assessment with this committee, and then have a session on that. And in some ways, that would be a really good starting point, because it is quite a detailed document, even though it's an overview of the whole of adult social care and where it is in Wokingham at the moment. So I think that'd be a pretty good starting point, because I think there might be things that you're particularly interested in for further meetings, and then we can have follow-ups. So I was going to see if I can share something.
No pressure.
Yeah, well, let's see. I'm not going to go through all these slides. I think I'll send them to you. How's that? Not too bad, is it?
Well done.
I mean, that just gives you a bit of a that gives you a kind of high-level structure chart of adult social care, and you can see where Lorna, Lisa, and myself fit in. We'll share these with you, so you've got a bit of a introduction. But really, I thought I'd throw it open to committee in terms of topics you might like to see over the year, or any questions that you might have.
Adrian. Sanjay and Helen, did you want to say something before we go to questions?
Yeah, so I mean, we've obviously attended to introduce ourselves, and so people know who we are. I know a number of you we've worked with previously and attended meetings previously, but others we won't have met. I think likewise, we're also happy both now and as we go through the year to receive requests for information to get sort of steer as to the type of areas you would like to focus on, or that it might be useful for us to discuss going forward. I don't know, Sanjay, if you wanted to highlight some of the sort of primary care side of things, because I know that's an area we've had quite a lot of discussion on in the HOSC meeting previously.
Yeah, brilliant. Thanks, Helen. And yeah, thank you very much. And thanks for inviting us today, and welcome to the new people that we haven't met before. So as Helen said, I've only come to one HOSC before, so I'm not a dab hand like Helen is. But yeah, we're really keen to work with you around primary care services. And when we're talking about primary care, we are talking about the GP, pharmacy, optometry and dental. I think when I came to the last HOSC, which was about January, February time, we just launched our draft primary care strategy, and within that we were doing a piece of that was an engagement piece with you guys, and the final draft has or the final version has now been published, which I'm happy to put in the chat, or if you haven't got it, I'm happy to send it over to you. In terms of that, shows the sort of the direction of travel for primary care. So again, however you want to feature this, please let us know and we're happy to work with you.
Lovely, thank you. Alice, did you want to say something there? Because we can see your face now, which made me think you wanted to say something.
No, thank you, Chair. The same. I think, feedback is very important. How the public receives messages is also very important. So I think, if we can all work together to get the message right to the public, that you'll get their trust back as well. So I think, collaborative working is the way forward, but, and silo working doesn't work. And, we need to have the messages the same. That's the ask.
Thank you, Alice. Matt, did you want to say anything else?
No, not really. It was just to hopefully have it agreed that we can bring our peer review report on our self-assessment to the next session in September. And then really it was to the committee to kind of, there might be things that are on your mind about health and social care and things that you want to go on the forward plan.
I'm sure Madeline's taken a note for the September agenda, so we can go through it then, and hopefully we will have relaxed a bit then and a bit more. Rebecca. Oh, sorry, Rochelle.
I had one question. Is there any progress on having the new rebuild of the Royal Barks in Wokingham, rather than trying to rebuild it? Has the government, since the new government said they're actually going to give us the money, as opposed to the last government which refused to do it?
Perhaps Adrian and I can answer that, being governors. And the answer is we don't know. We haven't heard anything at all from the new government. I think the Prime Minister's been abroad most of the week on other business.
I mean,
well, Helen might want to come in. I mean, I'm not over the high politics of this, but I know Andrew Statham from the hospital comes to Wellbeing Board and does give an update quite regularly. But I'm sure, I'm looking at Helen now, I'm sure he wouldn't mind coming here at some point. My understanding is that it might be better if that's sort of winter spring time, because there's a bit more activity planned for that time, so you might have a bit more to say. Am I right, Helen?
Yeah, I think that's right, Matt. I was going to say pretty much the same thing. So Andy committed at the last week's Health and Wellbeing Board to give a quarterly update on the programme there. And as Matt says, I'm sure would also be happy to attend, along with our Director of Strategy, Rob Bowen, who is leading on that work from the ICB's perspective. So happy for that to be tabled in and to liaise with Madeline around timings. I think you may be right, Matt. It's probably something we should wait a little while in terms of having more information to share.
We'll leave that to you then, Helen and Madeline, to get together to work out what the best meeting is for you to come and bring us up to date on. Thank you.
Chair, can I share something in this sense? Sorry. Just to share with you, the team from the hospital new development did come to Wokingham last Friday and asked the community leaders about their view about the changes that were taking place, especially 2 sites that have been addressed. The team are going around at the moment, or in Berkshire West, to getting feedback. So, and they have done an online event as well to share this information. So there is a lot of development, I think, and I think having them come here regularly would help, because a lot of the feedbacks that we are getting is most people are getting very frustrated because it's continuous conversation taking place, and this is since 2019. We need to get on and do something.
Agreed. Thank you, Alice. Yeah. Rebecca, did you want to say something?
I just want to talk about the forward programme, because I know we did talk about it a bit in the end of HOSC last time, and I know there's a lot of new committee members here, but there's a few of us that were here last time, and we did want to look at dental, definitely dental health. We received a presentation in the last HOSC, which was very useful, but hopefully we'd like to see some progress on that. One thing I've picked up on is pharmacies. locally and across the board, across the borough, the varying standards of them, particularly when we're referring a lot of people to go to their pharmacy rather than to their GP. So I think that is one area that I'd like to look at. And I do remember, I'm trying to remember, there was a particular strategy that came to us from Wes last. Can you remember what it was? And we were meant to receive a follow-up, and it's a particular strategy. And is it for learning disabilities? I can't remember what it is. We were meant to receive a follow-up for that
Perhaps
as well.
we can go back through the minutes.
Yeah, maybe
and find out.
what was it for? Is it that one? I didn't think it was. I think
It is
something else.
Wasn't that
Maybe it was called something different.
I'll find out. Wes is on leave at the moment, otherwise he would have been here tonight, which would
Yeah.
have been handy, wouldn't it? But when he gets back from leave, we'll ask him and we'll come back
Yeah.
with that.
Okay.
I think you're right. I think it was something to do with the market shaping strategy for adult social care, but
Yeah.
we'll check.
There was something, and
we'll come to the forward programme at the end anyway. So
I was just thinking if that would be
yeah.
kind of the areas that I think we wanted to look at.
Okay, you're happy to move on, Adrian?
Yeah, I'm particularly interested. We seem to have co-responsibility now for our adults, which is absolutely the right thing. And I spent a lifetime in IT working with different systems that don't talk to each other. And what I asked at previous HOSC meetings was, what is the handover process across different organisations? So where a resident is going into hospital, or somebody in hospital is coming back into the community and coming back requiring a care plan, etc., etc. So, in my experience, these kind of interactions are normally resolved by a technical solution, firstly, i.e. handing records or updates between organisations, and then secondly, taking responsibility for the new cases, for the new entrants, whatever. So I asked the question, if we could have a new KPI for WBC, which would be, the delivery of a technical solution, so that both organisations, ICB, ICS, and adult social care, know who's coming down the line. And the reason I asked this is because the process definition is, we phone people up, they might pick up, they might not pick up, we might send them an email, we might send them a follow-on email, we might have to ring somebody else, we have to change departments. This is a massively labour-intensive process when you don't have an IT interface between two organisations. And as you're constantly exchanging responsibility for the same individual, it makes sense to have some IT support for that.
So I'm not going to pretend we've got systems that are all lovely and joined up, and that isn't an issue, because that wouldn't be true. But we have got a quite well-established programme and system called Connected Care, which we've spent a lot of time getting operational and addressing some of those issues. So it might be worth, again, I'm looking at Helen, because that's something we have funded together through the Better Care Fund. We can do an update on that to show how far that's come and where it is, and that's used to share information between bits of the NHS, but it's also used to share information and so that systems can be viewed across health and social care.
An update on that would be fantastic. Thank you. I think there was also an update we requested on the HR workforce plan as well, I believe.
Yeah,
Was that what Wes came with, the workforce plan?
we've got a
I
workforce
think it
development
was.
plan. Yeah.
I think that's exactly what it was. Maybe that we need to have a review of that and see where we're at.
I mean, yeah, yes, we'll bring that back. But you know, while I've got an audience, social care workforce issues is one of the biggest issues nationally for social care that we need a solution for, both pay and a kind of plan to produce a new social care workforce. Some of the statistics around the vacancies in the workforce, turnover, stress, levels of pay, and the fact that many workers in social care are getting close to retirement age, and then new workers aren't coming in is a real issue. So I'm happy for that to come back to show what we're trying to do locally, and that it comes against that backdrop.
Matt, that's a huge amount for September. Are you happy for it to come back to September?
Oh, I was hoping it was going to be spaced out. Yeah.
Right. No, we can do that if you can negotiate with Natalie.
Yeah.
No, that's fine.
If it's okay, we'll space it out.
No, that's fine.
Yeah.
Are you happy that we move on to the next item on the agenda? And it's a separate paper of the all-age autism strategy. And Matt, I think you're introducing this, are you?
I am introducing this, and online, someone's just joined us, which I'm immensely relieved about, because Sophie Kendall is the officer that's led this piece of work, so is really close to it. And the reason she's joined a bit late is that there was a consultation launch meeting this evening. So I think Sophie's come straight from that. What I would say about this is it's not my strategy. This is an all-age autism strategy, so children and adults, and it's also something that we've done with health partners. I did that without moving my fingers. There, I've put a presentation up. We've done with all health partners, but we've also worked very closely over quite an extended period of time, a bit longer than we would have hoped, with voluntary sector organisations and people with lived experience. So there's a steering group that has helped put this together. We have a draft strategy. That draft strategy is now going out for consultation, and Sophie's arranging and leading that. That's a 6-week consultation period. We then, after that, we'll collect the feedback from that, and then we're looking to get the strategy adopted October time to executive, and November probably for Health and Wellbeing Board. One of the things you may well ask about the strategy is, so what difference is it going to make? Because we are all in a world of high ambition, but also high levels of need and low levels of resource. The answer to that is that the first stage is to consult on the draft strategy and sign it off. And then the same process that put the strategy together will put an action plan together in the autumn. So one of the things I also wanted to say here is I think it would be nice if we could have a discussion about this today, but also then bring that action plan back probably early in the new calendar year here to have a look at here. And one of the things we have done in our children and our adults money plan in the MTFP is squirrel away a small amount of money for that steering group to decide what the thing that would have the biggest impact to support the the delivery of the strategy as part of that. So we look forward to hearing what that might be as well. So I could go through the presentation, which would basically present what you've already had. I wonder whether it would be better maybe to go to questions than do that.
I think that's right.
And Sophia, it might be better if you can put the presentation down, because I think then it's easier for us to see you as well. Then.
Hi everybody.
Thank you, Sophie. Can I ask the first question is, why are we doing a consultation when schools are about to break up and folk go on holiday?
Good question. And obviously I'm here from an adult's point of view.
Can I answer
Sophie,
that one? Yeah.
Yeah, Sophie, you can answer that way. You did the launch tonight, so how did the feedback on that go in terms of, unfortunately, on our screen, you're all covered up. Teams has done a great job of putting the room over your face. But do you want to answer that, Sophie?
Let me see. Can you see me now?
No.
No.
Well, you're there. You're there.
No?
It's just
Okay.
that the room
Right.
view on our screen
Okay.
is right over your face.
Okay, I'll carry on. Yes, that has obviously been a concern around the timing of the consultation. What happened was the general election meant that the consultation couldn't go out for the send and inclusion strategy at the time that it was meant to. So there has been a delay. It's been discussed with all relevant stakeholders, and the strong preference of families and organisations supporting families that have been involved is that we should press ahead with getting it out to consultation to make sure that we can start delivering on the strategies come the autumn with co-produced action planning. What we are doing is making sure there's various routes for people to take part and getting out to as many groups and holiday activities and things like that as possible to try and get that input, but totally recognise the timing isn't ideal. We had a good showing of parents at the meeting tonight, and yeah, we're hoping that we're going to get more opportunities to bring people in over the next 6 weeks.
Yeah, the other thing I would say to that is this strategy is definitely not a group of officers gone into a cupboard and written something and then said, what do you think about that? The strategy itself has had an enormous amount of consultation and co-production to get it to this point as well. So it's not, I suppose, the formal consultation before sign-off is a fixed point in time, but actually there's been a lot of input into the document today.
Lou?
So I was just going to make a comment to say that as a governor at a school, I know schools have received it and I know that they have sent it out. So that has already happened.
Right, thank you.
Rebecca?
It's just an observation, really. I mean, it's a huge document, just what you presented to us tonight. This, it's how many pages long, and it seems very ambitious. There are lots of things that you want to achieve in your ambitions. And I'm just thinking, with the current situation, obviously we don't know what's going to come down the line with funding. Children, we know, are big waiting lists for any kind of diagnosis anyway. And, one of the big things I picked up, there was, 74% of parents said it was not very easy to access services. So, I mean, you look at it all, there's so much in it, but it's very ambitious for you. And it'll be good to see what you kind of get your action plan in October. So it's more an observation than anything.
Yes, I think I sort of share your worries about that. But I suppose the themes are mapped to the national autism strategy, so that naturally we've taken those. And I think for the parent carer groups, people with lived experience and the voluntary sector, I think there was a real will to be ambitious in that strategy, and that's come out. But I also think people understand the kind of resource strangled world that we're in as well. So I think that action plan and putting that together will be a bit of a tricky conversation for sure. But I think I'm pleased that the ambition's there, I suppose, and that's why we put some money aside to help with that. It won't do it all. It won't do it all at once, but it will give us a step in the right direction.
Adrian.
Yeah, I was out and about on Saturday, and I started talking to a family, and they said they'd moved to the borough, and the previous borough hadn't got a clue about SEND, and they said that their two children are really enjoying Embrook, and they're having a much better. Embrook is having a much better understanding of their situation than they got in the previous borough. So it was a very positive call out for Embrook School.
It's good to hear.
It's really positive. Yeah.
Yeah. And the strategy is about trying to make that consistently the experience for everyone.
Yeah, Fiona.
Yeah, I have a very similar concern as to Rebecca, really. I thought it was very ambitious. I thought it was very, very good, but extraordinarily ambitious. And my concern is that I think, well, I guess, how are you going to prioritise? Because we could very end up doing a very little of everything and achieving nothing.
I think I'm just going to answer that in the same way. I think, I understand your concern, and I kind of share that myself, especially as I'm on the sort of sharp end of delivery and accountability. But the process today has been everyone working together to come up with something that's quite ambitious. The next process, once that's signed off, is then about having those conversations about prioritisation and what we can deliver. I think one of the things that's important to that is listening to those people with lived experience in this space, because usually the most important things to address come up that way, rather than professionals deciding that. So I'm kind of confident that some of that will come out, but I think that's why we kind of need to bring that action plan back here.
I think it's a bit like being a parent, isn't it? When you've had your baby, you're very ambitious for it. And when it's 20, you realise what you've achieved. And so we get used to it. So we look forward to what we can do and accept, hopefully with grace, what we can't. But we'd like to. Any more comments? Oh, sorry, Sarah. I can hardly see you on there.
Oh, thank you. Yeah, I mean, I suppose it's just a couple of points, really. I mean, I'm a parent of a daughter who's been diagnosed in the last 2 years, who's a teenager. And just as those comments have been made about Embrook, I can also say that the provision that they've had once they were diagnosed at Bowhunt, I was also, we've been really, really pleased with, which is excellent. I guess just kind of tying into that context about the ambition of the strategy and perhaps how wide that strategy is. And read it, there's one paragraph that mentions we don't want autistic people to have to wait until they've had a formal diagnosis to receive support, and that we will ensure some intervention is provided at the earliest stage possible. And I guess I don't quite know how to phrase the question, but I guess I have some skepticism about that trying to enter that that diagnostic channel is very difficult and can take a long time. And even once we got the diagnosis, it then took quite a long time to engage the right people to get that support in place. Once it was in place, it was excellent. I just don't quite understand what that means about, is that expecting the person to, how they would assess themselves and then how they would go about advocating for themselves to get the support they need when people are already struggling to get a formal diagnosis. I hope that made sense.
It does. It does make sense. And I think there are two strategies that are going out for consultation at the same time. This is the all-age autism strategy, but there's also the send and inclusion strategy that's out as well. That's gone to the Children's Overview and Scrutiny Committee. And I think the two things do need to be sort of looked at and read together. And I think, Sarah, I think what you're describing is a system, a kind of system and a battle, I suppose, that a lot of families have had to go through in order to get a diagnosis, to get some services. I think there is a general recognition now that actually more of those services, more of those supports should be ordinarily available and accessible to people earlier, so that people don't need to go into a crisis and demand a diagnosis to get the services they need. And that's what that's pushing at, to try and improve that. Again, it's a huge ambition, and you know, the action plan might bring us baby steps around that, but that's what that's pushing at. It's not an attempt to say, well, over to you to do that yourself. It's more about having things that are ordinarily available earlier, like speech and language therapy and things like that.
Thank you. Any more? Nagy.
I'm fairly new to this subject. Apologies if it's the wrong question. Does EHCP come under this subject as well?
Do you want me to answer on that?
No, well, you go on, Sophie. That saves me
No, it's great.
droning on, but I can do sort of yes and no is the answer. But Sophie, give you a better answer.
Yes, so the parallel strategy, the send and inclusion strategy, addresses the whole system of support for children with special educational needs and includes EHCPs. The all-age autism strategy is for all autistic people. That includes autistic children and young people who do already have an education, health and care plan, and many who don't and may not need one too. So it is in scope, but the delivery of progress around that particular agenda, so around EHCPs and all of that planning, is more under the remit of the send and inclusion strategy, but that is part of the benefit of aligning both strategies and action plans where they overlap. So we will make sure that autistic children's needs and feedback is properly reflected in the work that's happening as part of the send and inclusion strategy and that action plan to deliver progress in that area.
Yeah, well, that was a better answer than me. And all I would say is probably one of the reasons you're raising that is there's a lot of tension, I suppose, to EHCPs and who gets them, how long it takes to get them, how many we have. That is a real focus of the Children Overview and Scrutiny Committee as well. You know, they spend a lot of time looking at our send services, and that's why the strategy is coming out there. So that's sort of where that's looked at.
Thank you both. I have a follow-up question. So within that strategy, are we doing anything to increase the school places? Because I've heard that the schools that within our borough are very less who accept EHCP, children with EHCP. So
yes, so there's a huge amount of work going on as part of that strategy and action plan to increase capacity in schools. So opening new schools, but also increasing capacity within existing schools to better meet the needs, recognition that there's catching up to do in that area.
Any further questions on this? Are you happy to move on? Sorry?
That's a legacy.
Sarah.
Yeah, is it a legacy hand, Sarah, or do you have another question?
Sorry, no, I don't. Apologies. Not driving
no
this
problem
very well.
at all. No. Right, we'll go on to the next item on the agenda, which is an update from Health Watch. So, Alice, it's your 5 minutes of fame.
Only 5.
Well,
Thank
no.
you. Thank you, Chair.
Yes. Thank you for coming.
Thank you, Chair. I am aware that you have an update with you that was sent to you some time ago. So what I would like to do is give you a further update of where things are at the moment with what's the activities of Health Watch, if that's okay. Is that okay, Chair?
Yes, Alice, it certainly is.
Thank you. Thank you. So just to share with you that the themes that we are seeing at the moment from the feedback that we are getting is about hospital, as looking at referrals and diagnosis. Under GP services, we are receiving things like record access, blood results, and registration. We are now new one that we are getting is about NHS 111, which is about the delay of to call back. We are still getting feedback about drug errors from pharmacies, medication no longer available. Dentistry, no dentists are available either and having difficulty to register. And the other thing that is also that's coming up as a feedback is about families not aware about power of attorney, whereby whereby they cannot speak on behalf of a relative without documentation. So that's been another thing that we've been having. You are aware that we have been doing this GP Access project since last November, and due to illness and election silence, this report has been delayed. And we are hoping that it will be out end of September after getting the response from the Bob ICB primary care lead. Soon, the dentistry and learning disability report will be out. Again, delayed because of the election. We've also been busy with the annual report, which is now in the public domain. And I'm sorry, Chair, that you did not receive one, but I think your previous chair did receive a copy, which is one of the mandatory requirements. But I'm happy to.
He's nodding, Alice.
Thank you. So, but I will share with you the report as well. I will send it to Madeline. In February, we went out to the public to ask about what are the priorities that we would like us to look at regarding health and social care. And the priorities that came up in your papers, you will see, was social care at home. And now we have changed the thought process. We are looking at unpaid carers, experience of health and social care, specifically those who are male carers, not, so because there are few male carers around who are caring for their parents or partners. With health inequalities, one of the things we are looking at is targeting the South Asian women. To ask them about access of information and access of services. We will also be looking at primary pharmacy first and also youth health. We may not be looking at maternal health this year. However, we've in the papers I've also shared with you about a document that is that we have shared with the Integrated Care Board about the funding that was coming out to the Women's Hub. We have held the ICB to account to find out what happened to the funding, and we have had a response, and we've been informed that 300K has come into Berkshire West for the Women's Hub. Where the money is going to be, or where the hub is going to be, we don't know yet. And that is my update. Any questions? Happy to take.
Lovely, thank you, Alice. Any questions? No one's indicated, Alice. You've got off lightly.
Thank you.
I'm just looking again to check, but no, everybody's happy. Thank you very much. And
Thank
it's lovely
you.
to see you.
Thank you. Bye-bye.
Bye-bye. See you next time.
Thank you.
Item 12 on the agenda is the forward programme. And you'll see for the September meeting, we've already got primary care and the KPIs. We talked tonight about having a couple more things in September. So, Madeleine, I'm sure you'll add those. Is there anything else that we think needs to go on there? Alice gives us an update at every meeting, for those of you who are new.
Oh, I'm conscious that we've got 4 meetings and there are 8 unscheduled topics from last year. So I think we need to crack on with some of those. And obviously, it's going to be whether the people that we want to question are able to attend in September.
Can we leave that with Madeleine to see if they can and to arrange so? And Madeleine and I work together on it. Some of them I think are more important than others. And I'd like us to prioritise those if we can. I think vaping in primary school children is something that we need to look at as a matter of urgency. I don't know what others think. We know about dentistry, we know about doctor surgeries provision.
Do we know? We're always looking for an update, and we're always here to challenge what's going on.
Yeah, I think.
I mean, I would question: is there data available about vaping in primary school children, or who is it that we're going to be talking to about how they're challenging and seeking to deter and prevent and stop it?
I think because that's a new subject, it's worth starting to look at it. The others are updates, Alison. I think they're all important in their own right.
2 of them are entitled updates. Not having been on the committee except subbing last year, and these being very brief headings, it's not completely clear, and I'd welcome previous members of the committee to expand on why they were added to the programme, you know, the ambition of last year's programme.
Well, perhaps we can go back to Adrian for that, as he was chairing those meetings. Can you remember why we added them on, the unscheduled things? Sorry?
I can help if that helps. So in terms of vaping in primary school, it was a suggestion from a previous committee member because they'd heard anecdotal evidence from residents that it was becoming more of an issue, and it was suggested that it might be something that the committee wanted to get an update from, I think particularly trading standards, because obviously they're the ones that deal with like the licensing and age appropriate sales, and potentially public health. And it was suggested that if you did look at it, you may also want to invite the children's scrutiny committee members, so you have essentially a joint item, because obviously it'd be something that you're potentially both interested in. The other items have basically come out of previous meetings throughout the year, and some of them haven't been scheduled because they say the particular individual that we needed wasn't available. So they've just been brought forward in case members still want to look at them. What I would say is that you do not necessarily, if you think that they're no longer an area of priority, need to necessarily take them forward, or if something comes up which you think actually this is something that we need to look at more. These are just suggestions, but if you do obviously want to still look at these areas, we can look to scheduling these at the most appropriate time in the year.
Rebecca and then Michelle.
I just remember as well, we talked about GP provision, especially in new.
Wokingham surgery.
No, this was particularly in a lot of the new housing developments coming, and the fact that we know with the they wouldn't, it's just an example, Arborfield, don't get me started on Arborfield, but they originally said they would provide a GP surgery, and then they've pulled out and they've spread it out amongst other surgeries. And it was just about looking forward, especially because we know we're going to have more houses, what the provision was going to be and how it was going to be managed. So we did ask if we could specifically look at that. We did ask about dentistry, and I think that's a really important one because it's a really, really big issue still for Wokingham.
I think it's time we looked at dentistry again. It must be a year since we looked at it.
And I would, ask if we could possibly look at pharmacy as well, the pharmacies across the borough, because there seems to be such a wide discrepancy about quality and especially when we're telling so many people, and you see a lot of these things now directed about self-care, go to your pharmacy, but the standard amongst them is very incredibly variable.
I mean, I'm happy for us to look at those three things and see where we can fit them into that meeting, who we need to talk to. But we had that dentist from High Wycombe, was it? Yeah, who came. But I know I talked to my dentist about it incessantly. And it's very difficult, especially if you've got children. What do others feel about it, Rochelle?
The NHS app you were talking about, one of the things you were talking about, they've reduced the amount of information that they're allowing people to see now. I used to go back in there and check what my HB1ICs were for the last few years, and it's disappeared now. And I think it should be there, if you want to see how well you're doing versus what's happening, but it's not in the app anymore for some reason or another. There are some things in the app, but some things that seem to be gone. I don't know if just the surgery did it or who did it, but I went to look and it wasn't there.
I don't use it. You need to be diabetic really to use it. Lou?
I actually completely agree with Rebecca. I think when I saw GP access on the list, and it's the biggest thing that residents talk to us about, whether or not they're from new estates, and obviously the fact that we now have 2 private primary healthcare clinics in the town centre means there's obviously a market for that, so it's clearly an issue. And dentistry, my kids have been on a waiting list for a year to get to an NHS dentist, so and I know again that's the end of one, but it's something that people talk to us about a lot, so be good to know.
They're 3 big subjects, aren't they?
The pharmacy one's really important as well because of the because of the sort of the use of
don't go to GP.
And I know some of the residents and the public do have concerns about that, rightly or wrongly. So it would be good to understand a bit more about that.
Oh, sorry.
So with regards to the GP surgery, so I have a surgery that doesn't have a GP for more than a year and nothing's been done, and all the residents are just going around in circles. Yes,
Thank you. I think those are 3 really big subjects that we do need to review. We've looked at them all before. Rochelle?
Unfortunately, NHS surgeries are individual businesses that contract with the NHS. It'd be much better if the doctors all worked for the NHS, and then we could actually put them where we want them or need them. But this way, it's a private business, and we can't do this. We can't even ask for one. The Berkshire Trust decides whether we need one or not. And even then, they can't find anybody to do it.
And that's the same about dentistry. They're private businesses now. But I understand that the new government are going to look at the dentistry contracts, but whether that'll make any difference or not, we don't know. Adrian?
So I'm not sure what point you were trying to make, but if you've got a constituent who's not getting a GP surgery for a very long time. The person to talk to, the person responsible is Sanjay, who was on the call. Yeah, so he's responsible for the primary care network in this Bob ICS. So he should be your contact.
But yeah, we could have him in and ask him questions. It's a difficult position if you can't actually get bodies to work in the surgery. So I don't know what the answer is.
How can you help? You should help.
Any more primary care doctors?
Yeah.
I feel like we're trying to jump into solutions for this, but I think still think it's a valid topic, because I think there's lots of questions that could be asked that go deeper than some of the things that have been said here.
So GP surgeries in new built areas.
Not even just new build, to be honest.
Yeah, but especially in new built areas when there's no surgery at all. Yeah. Dentistry all over the place, and pharmacies all over the place.
Yeah, I tried to challenge with the CCG for 4 years their algorithm for allocating GP surgeries, and I never got a decent answer from the CCG. Now the situation is absolutely clear with regards to Wokingham. You know, we have since the last census, we have a massive increase in our population, especially the over 60s, over 70s, where the population has gone up 43% in 10 years. It will have increased since then. And we've had no new GP surgeries. So we again have to challenge that algorithm. You know, they have to present to us how their algorithm is making the decision that we don't get any new GP surgeries. We must challenge this.
And we forget that they're now looking at Barks, Books and Oxon with that same algorithm. Sarah?
At the next meeting, which I think is it September or October? Sorry, I'm not entirely sure.
September.
Is it worth us weaving into it ties in with all of this, but about winter pressure planning as well for the borough? Just thinking particularly around, primary care, GPs, and whether or not there's going to be any ARRS funding coming in again this year, because that can be allocated to, I know it's not very popular, but locum spend as well. So just wondering whether or not that's worth being on the agenda in addition to this, just around winter pressure planning.
Yeah, Madeline's just written it down. And do you know who specifically we'd deal with about that?
I mean, it may tie in with Sanjay again, I guess, because a lot of it happens in the primary care sector. Yeah.
It will be a mixture of officers, but we can look into that.
Okay. Okay, are we happy to leave it at that, and we'll get Madeline to sort out who and when to bring those forward. Thank you very much. The meeting's over. How did you feel about it as new member?